Our next panelist is Stanley Lalta, who I'm sure all of you know. He's a health economist with over 20 years of experience in teaching, training, consulting, and direct policy operational research in health matters in the Caribbean. His special interests are in health financing, health policy, health reform, national health accounts, and pharmacoeconomics. That's a new one for me, Stanley. Pharmacoeconomics. He's a graduate, of course, of our University of the West Indies, and he's been in many faculties, including public health, and he has completed his postgraduate and doctoral studies at the University of Cambridge, University of York, and University of London. And he's, of course, now a research fellow at the HEU Center for Health Economics here. And he's going to give us a presentation on efficiency in managing chronic diseases, looking particularly at something we touched on today, the availability of drugs, the comparison of 4 prescription drug assistance programs in the Caribbean, and giving us an idea as to where there might be advantages, where are there lessons to be learned, where the efficiencies being demonstrated more in one more than the other, and to what extent we can in fact highlight on this and get the message out to the policymakers. Stanley, over to you.
Madam Chairperson, colleagues, good afternoon. Professor Theodore's passion for mentoring and seeking to improve the quality of lives of people is legendary. I first encountered Professor Theodore as a student when he taught me Marxist economics. I never quite made it as a Marxist economist. My beard refused to grow to the length of Professor Theodore's. So I turned to health economics, and there I encountered Professor Theodore again. In a way then, so we've joined in what I can call a passionate partnership, working through health and economics to try to improve the lives of people in the Caribbean. The presentation I'm going to look at really should be in 2 parts, management, but I really want to focus in this particular presentation on the design side. Not so much the performance side, which is the second component of this that will have to come probably in the next conference. My collaborator, Lena Ramaratan, is here with me, so she can fill in where I do not completely fill the gaps. The matters of burden of disease, equity, efficiency, access to essential medications, financing, costing, all came up this morning. And what I'm trying to do is to do a presentation which captures a lot of these by examining the role and the design issues in these 4 prescription drug plans in the Caribbean, which were designed specifically to deal with this major burden of chronic diseases. Let's just step back a bit. In fact, many people still misunderstand chronic diseases because we think it's a problem for rich, not poor countries, which is wrong. It's for rich people, not poor people, which is wrong. It's for old rather than the young and the middle-aged. That's completely wrong. Men more than women, that's completely wrong. You can't prevent it, that's completely wrong too. And the fact that some people lived up to 90 years and they have no problems, and therefore it shouldn't affect us, completely wrong also. CNCDs are very big in the Caribbean and elsewhere, and it affects not just individuals and their families, but it affects the economy, it affects health systems, productivity, competitiveness, introduces fiscal burdens into the country, affects the whole matter of poverty, health inequity, and so. What's the problem in the Caribbean? Here's where we are. 75% of the burden of disease, chronic diseases. The rest of it is communicable and injuries. Of the communicable diseases, cardiovascular, cancer, diabetes, respiratory diseases are the critical ones. Premature deaths, about the same percentage, 75% of premature deaths in the Caribbean, also due to chronic diseases. Economic burden, 2 studies I've pulled out, one, an early one done by someone called Barcello out of Paho, looking at diabetes alone in 4 countries and saw that it was costing us about 3% of the GDP to try to manage diabetes alone. On a per capita basis, it was about US $687, while total health spending per capita was only $302. So diabetes was costing more than twice what the whole health system was getting for running their services. Another study, someone from University at West Indies in Jamaica, Abdul Kadri, who I have just seen in the audience somewhere, so he can fill the gap a bit further. He looked at diabetes and hypertension in 4 countries, Bahamas, Barbados, Jamaica, Trinidad, and Tobago, and jointly they accounted for about 5.2% of GDP, which, if I recall, is higher than the estimated fiscal deficit in Trinidad and Tobago in the next budget. So can you imagine a disease or a group of diseases affecting your GDP in such a very large way that it poses all of these fiscal problems? For example, across the Caribbean, Bahamas is about 1.4%, Barbados 5.3%, Jamaica 5.8%, Trinidad and Tobago 8.0% of GDP affected only by trying to manage the problem and the complications associated with diabetes and hypertension. So where do these prescription drug plans come into the picture? 4 countries have set up these plans, and really the critical issues pertain to the matter of access. Many times there are persons who go to the public system to try to get a medication for the chronic disease, not available, return, come back. Sometimes you go back and you only get part of it, or sometimes you do not ever get the medication, you're left without. You try to go to the private sector to get it, and then the cost becomes a burden. And then we can very easily put our fingers on who are the ones who are so terribly affected by the unavailability of medications or by the cost issues that they have to face in the private sector. With medications, you can try to improve compliance, you can have less complications, you can improve your quality of life. So all of these are matters which a prescription drug plan tries to deal with. But there are bigger issues for the health system that gets into the picture, because you want to encourage the use of more cost-effective medication. You want to reduce the cost of complications, of surgery, amputations, blindness, etc. in the rest of the health system. And overall, you want to reduce the burden of chronic disease. In a larger social setting then, what you find is that prescription drug plans become an important part of what is called a social safety net. I understand now in Trinidad that that has been questioned as to whether you need to have a chronic disease prescription plan or not, or whether it's appropriately targeted. This matter of equity becomes a very crucial part in this, because there are some persons who clearly, because of unavailability in the public sector and because of high costs in the private sector, are having access issues. Thanks to Amalia Del Riejo, I've borrowed a slide which brings out the matter of equity very clearly. The matter that we're distinguishing between that and equality. Equality, 3 people want to watch the game, each one has 1 box to stand on. Well, first, certainly the guy on the left doesn't really need a box. You can see the game without it. The one in the middle, probably. But what about the one on the right? For there to be equity, there must be movement away from those who have more to those who probably need more. Now, how are we going to get that person to give up his box? He sees the game, the one in the middle sees the game, or the one on the right now will have to get 2 boxes instead of 1. That's the equity you're seeking. How do we try to get the person on the left to give up his box? Is he going to do it voluntarily, or do you have to have a system to enforce it? And that's one of the critical things that a health system seeks to do when you speak about equity in access. 4 plans: Barbados, Drug Service; Jamaica, National Health Fund; Trinidad and Tobago's Chronic Disease Prescription Drug Plan; and Bahamas' National their National Drug Plan. Some of their features: Barbados since 1980, Jamaica and Trinidad since 2003, and Bahamas in 2010. And different ways of managing the system, different mix of diseases which are covered, different eligibility issues. Barbados covers a list of about 5, but the cancers are very large group. So it's actually about 10 conditions covered in Barbados. Jamaica about 16, Trinidad about 12, Bahamas about 14 conditions, all critical in the countries. So what's the criteria I'm going to use to look at efficiency in their design? 10 overall criteria. As I said, I'm looking at the design side. I'm not actually looking at the performance side yet, which is going to come up in another presentation. And the features are organized as such. I'm using a simple binary scale. If you score 1, then you are good. If you score 2, then you're on the wrong side of the design framework. You need to do better. What's the source of the funds? If it's diversified as against single or sole source, then that's better. Where do you get your drugs from? Is it a public tender or you go to the open market? What's in the drug formulary? Is it defined or is it open-ended? The drug formulary determines what are the drugs which get prescribed. What are the prescribing protocols? For example, for any particular condition, you have what can be called the minimum, depending on whether it's a low impact of the condition or it's a very high impact of the condition. So you can have a low to a max. And so you can have a drug protocol which looks at prescribing patterns, X amount for a month or X amount for 3 months of this particular dosage. That can be defined in a protocol according to what your professionals, your medical professionals can put to you. If you have it defined or if you have it open-ended. Do you have a network of pharmacies? And it is network contracted, so they have legal obligations, or is it any willing provider outside there? How is your claims processing system organized? Is it online, real-time, or is it a manual system? Do you have any co-pays within the system? Some co-pays are important. If you have no co-pay, that becomes an issue in terms of overall sustainability and equity. Timely reimbursement. Do you reimburse your pharmacies on a weekly basis, or does it take longer than 1 week? Because remember, they have obligations to the bank to repay. Do you have a health promotion, health education, community involvement component in your drug plan, or don't you have that? And overall, how is cost control going to be? Is it going to be managed, or is it going to be very limited? And these are the key features, or the key criteria I'm going to be looking at when I examine the 4 plans. So where we are: Barbados, Jamaica, Trinidad and Tobago, CDAP, and Bahamas. Source of funds: Barbados has a single source of funds from the budget, which is bad. That's why they scored 2. Jamaica is diverse, which has a triple source of funds. Trinidad, a single source of fund just from the budget, that's bad. Bahamas, single source, that's bad. Drug sourcing: Barbados is good, public tender. Jamaica is bad, they go to the open market. Trinidad is good, Bahamas is good. Do you have a defined formulary? All of them have defined formularies, which is why they all score 1. Prescribing protocols: is this carefully defined by a panel of experts or not? Barbados is open, that's bad, which means that persons can get any amount of medication at any point in time, which leaves it very, very open to abuse, but also to cost, to lack of cost control. Jamaica is defined, Trinidad is very open, Bahamas is very defined. Network of providers: all of them have contracted providers, which is good. Claims processing: Barbados is manual, which is bad. Jamaica is online, Trinidad and Tobago is still manual, and Bahamas is online. Co-pays: Barbados has some, Jamaica has some, Trinidad has none, Bahamas has none. Reimbursement: monthly in the case of Barbados because it's manual. Jamaica is weekly. In fact, you can get your money on a daily basis if you want, because it's all online. Trinidad is monthly plus, depending on how quickly they can process your claim. Bahamas is weekly. You can get it on a daily basis if you want. Health promotion, health education component: Barbados does not have that in their plan. Jamaica does. Trinidad does not. Bahamas does. Overall cost control: Barbados is limited. Jamaica is limited. Trinidad and Tobago is limited. Bahamas, it's much more managed. The closer you are to 1, the better you are. And as you can see from the scoring, both Bahamas and Jamaica are closer to what we're looking for and a better design compared to Trinidad and Tobago and to Barbados, which have major issues with the design of their plan. There's some additional data on how the payment terms are organized differently in Barbados as compared to Jamaica, compared to Trinidad, compared to Bahamas. What's my key observations and the key findings in all of this? Well, certainly plans are designed to improve equity and access, especially by the groups who were certainly disadvantaged in getting or not getting drugs in the public sector and being unable to afford it in the private sector. Improve access, less burden of payment for them, but direct cost sharing is not equitable. Where you don't have some cost sharing, then everybody, rich or poor, are going to gain from that, then that's inequitable. Increased demand utilization, but compliance monitoring is very weak. Plans are legislated in most countries, but single sourcing of funding is a problem for sustainability. Overall cost control is reasonable, but better auditing is required. And more we're finding that the health promotion, health education component may be absent or getting de-emphasized in some of these plans. My last slide. What are emerging best practices and the success factors? For these plans to be successful, to get close to the one ideal that we pointed out in terms of my design criteria, you need to have what we call end-to-end cost control. Define your membership, define the formulary, define your protocols for prescribing and for dispensing by pharmacists. Otherwise, you can get all kinds of excess prescribing and dispensing, which just makes a mishmash out of all your cost control. Procurement by tender, essential rather than going to open market. Your reimbursement formula must be done in a way that encourages use of cost-effective medication and cost control. Electronic data systems, critical, so you can track utilization, you can track behavior at every point. Essential also for auditing. You can know who is trying to rip you off or not. You can know which individual is getting the same medication 15 times for the month, and which individual is coming up all the time and telling you every time they return for medication within the same month, the dog ate the medication. We've had too many stories of dogs eating medications or to forget it in the taxi. Need various sources of financing, earmark funds for health promotion, education critical. Lastly, in all of this, there's a need for better research. Research on compliance behavior, because this is an aspect which is not fully worked out. What's the impact on complications? Has it reduced complications in the hospitals and in the rest of the health system? What is the extent of savings to patients and their families, to employers, to private insurers who are now getting a bonus out of government paying for all of this? And lastly, has it improved the use of cost-effective medication? Further work to be done, but that's part of what we intend to do for the next conference. Thank you all.
Thank you very, very much.